Good afternoon and welcome, everyone. My name is Ben Ryan. I'm a postdoctoral scholar in the Department of Psychiatry and Behavioral Sciences. Before we get started, I want to remind our in-person and live stream audiences that we will be accepting questions via the QR code that you will find in your program and on screen if you're watching virtually. A live Q&A will follow this afternoon's presentation. Today, it is my pleasure to introduce Dr. Nolan Williams, an associate professor of psychiatry and behavioral sciences and director of the Stanford Brain Stimulation Lab. Dr. Williams is going to discuss his team's discovery of a life-changing treatment for severe depression. He will also provide an inside look into Stanford's new Experimental Therapeutics Hub, where physician scientists are expanding avenues of research into non-traditional therapies, including the use of psychedelics, to tackle the most pervasive disorders of the brain. Please join me in welcoming Dr. Williams.
Thanks for having me today. It's super exciting to be here, and it's a great group with really nice weather. So yeah, really appreciate it. So I'm going to talk to you about 3 therapies that we have at various stages in the lab and kind of that process of how we develop new therapeutics for brain conditions. So the first problem that I'm going to talk to you about is major depressive disorder, depression more generally. So as some of you may know, depression is a problem that affects quite a few people around the world. Most of you probably have a relative that you know who's experienced depression at some point, or a friend. You know, it's a very common problem. It's the leading cause of disability worldwide. And the treatments that we have, the kind of standard treatments, the oral antidepressants, psychotherapy, that sort of thing, they take a long time to work, right? They take, weeks to months. And these are problems that need much quicker solutions, right? We need to be able to treat people in a matter of days. And particularly, we've been focused on the problem of treating people in the most severe conditions in psychiatric emergencies. So about 500,000 people will go into the hospital in the United States each year with suicidal depression, where they actually, feel so bad that they're thinking about ending their own life. And in those individuals, you actually lose treatment options as you go into a general psychiatric hospital, because people lose access to some of the treatments that are outside of the hospital. And so it's the one area in medicine where, as you escalate acuity, you escalate the level of severity of the illness, you escalate the level of treatment, you actually have less opportunities than as an outpatient. If I start having chest pain right now and one of you is a doctor and you check me out, you may have a few things for me, but I really need to go to the emergency room where there are more tests and more treatments, and I may need to go in the ICU where there are more tests and more treatments, and we're trying to really emulate that phenomenon within psychiatry and build tools for psychiatry to reduce that burden and then reduce the suicide risk that happens after somebody is discharged from the hospital. And so the first thing that we have to kind of think about as we think about making new treatments in 2023 is this idea that we understand these psychiatric illnesses as brain illnesses, as illnesses that affect neural networks in the brain. So whether it be depression or obsessive compulsive disorder or Parkinson's disease or Tourette syndrome, they all affect brain circuitry. And what's useful about that kind of view or level of thinking is that you can treat using therapeutics that are focused at brain circuitry, right? So circuit solutions for circuit problems. And so I'll show you an animation to kind of illustrate this point. And this is the first therapeutic that we developed. We called Stanford Accelerated Intelligent Neuromodulation Therapy. And the idea is that we're trying to get into a very specific brain circuit, one that is connected between 2 brain regions, one the prefrontal cortex and the other the subgenual cingulate. So you stimulate what we're referring to here as the target node, and then we enhance the inhibition and suppress the sadness area in the brain, right? And so the idea came from this evolution of the current way that we do neurostimulation treatment developed in the 90s, where they're average skull-based measurements that are measured, and the stimulation is applied in an average spot in the brain. But nobody's brain here is average, right? Everybody has a unique kind of constellation of brain circuitry, and you need a unique solution. So you can see that the old way of doing this, developed in the 90s, in many cases misses that brain target. And so what we do is we do formal brain mapping. We actually go through and get a brain MRI on each patient. We find this ideal spot for each person, and we know exactly, based off of that mapping, where to place the stimulation coil or whatever neuromodulation technique we're using. And with that, we can personalize each person's target and have the stimulation go just into the spot that we're looking to stimulate. And so that's one of the innovations of the technology we've been developing. The other one is around what signal you send. So once you know where to stimulate in the brain, you also need to know how to stimulate in the brain. And just like with Morse code, if two people know Morse code, I can send a message and you can receive it. We know how to send stimulation in a way that sends a signal into the brain for the brain to turn on, stay on, and learn how to stay on. And so it's based on learning principles and how the brain learns. And so in the case of this Saint therapy, we're able to send a signal in that's quite robust and that's much more dense than conventional stimulation approaches. So you can see, we give multiple sessions a day. Each session's about 10 minutes a day. And we give a stimulation approach that's based off of the way that the brain learns, based off of recordings from a brain region called the hippocampus. And so with that, we're able to give an entire course of conventional TMS in a single day and kind of reorganize the entire way that the stimulation works. So the old form of stimulation that has been used since the mid-90s takes about 6 weeks to work. This new form of stimulation we can fit inside of a psychiatric emergency within a 5-day course, and that's by having the stimulation reorganized in time. And so you can see the pulses are reorganized in time so that you can apply the stimulation over the course of a day to 5 days and get people well in very short periods of time. And that's kind of the base idea. We figured out where to stimulate, how to stimulate, and how much to stimulate in the brain. And with that, we get pretty significant and rapid acting effects that match the acuity of the problem. So folks that are having a depression emergency can get well in 1 to 5 days instead of weeks and months. And so that's the basic idea of this approach. And so with that, we've observed really dramatic improvements in efficacy compared to the standard stimulation, because we are stimulating in this kind of ideal spot, in the right spot for each person. And like I said earlier, a much more rapid approach, an approach that works in a series of days instead of months. And so most people can get well with this. We have data now where we can predict before people are treated who's going to respond based on their these similar sort of brain connectivity metrics. So Anish Mitra in my lab and Carl Dijsselroth's lab was able to demonstrate that folks that had a particular flipping of the signaling in their brain are the ones that respond. And so we can see that on the brain MRI before they ever get treated. We actually published that on Monday. So really kind of hot off the presses. So that's the first technology that I'll be talking about. The second one is this idea that for some people, a small percentage of people, but some people, they're really responsive to hypnosis, right? And so, this may seem like an unusual thing to start thinking about, right? That, people have heard about stage hypnosis, and there's actually a therapeutic application of this. People can actually stop smoking. They can do simple surgeries under hypnosis, but only a small percentage of people, like 15% of people that are kind of born with high hypnotizability. It's really stable. You can't, for the most part, nobody's been able to change that, and it's stable over decades, right? It's like a brain trait. So we asked the question of, could we stimulate the brain in such a way to shift the trait, to make people who are low to moderate hypnotizable, more hypnotizable transiently, so you could get in there and give them a hypnotic instruction to quit smoking, or to be able to go under simple surgeries without pain, that sort of thing. And so the idea is to stimulate one brain region, similar to the animation I just showed you, to affect another brain region. And you know, this is just what I was saying a second ago about that limited population. And so we found this connectivity pattern about a decade ago. Some folks on the team found this connectivity pattern in the brain that reflects high hypnotizability. And then we came up with this idea that what we're calling shift, or this idea that we can combine stimulation with hypnosis. And what we found is we can actually transiently make people more hypnotizable. So we can make their brain more hypnotizable. It lasts about an hour, and then it goes away, suggesting that you could, for people that say hypnotic smoking cessation wouldn't work, you could potentially make it work during that window where you opened up the brain connectivity. And then the third thing that I'll be talking about is looking at novel plant-based medications and therapeutics, what people are calling psychedelic medications, people call neurogens. And so we developed a treatment for individuals with traumatic brain injury that are, in this case, that are Navy SEALs and Army Rangers, folks who are Special Forces veterans. And so, and for a good reason, for those of you that have ever seen somebody with traumatic brain injury or know somebody with traumatic brain injury, there's not really any medications for traumatic brain injury. There's not really any therapeutics developed for that problem. And the therapeutics that we have for PTSD, post-traumatic stress disorder, and other things related to traumatic brain injury from a medication standpoint are limited. So we call this MYSTIC, or Magnesium Ibogaine Stanford Traumatic Injury to CNS Protocol. And so it's this idea that that the ibogaine, the substance, has, as you'll see, a lot of effects, but also has some cardiac risk to it. The solution for that cardiac risk is actually co-administration. We think co-administration of magnesium, and so by giving this combination, we're able to mitigate the risk of the ibogaine itself. Ibogaine is an alkaloid that's extracted from a root bark in an African tree called the iboga tree that's native to Gabon. And so what we found was that folks going into this, most of which make criteria for PTSD, depression, and anxiety, had a pretty significant resolution of their symptoms right after treatment. These are single subjects, so each line is one person. And you can see in the higher the line starts, the more symptomatic they are. So this person that's at the highest on the PTSD scale, around 55 or 60, that person has very severe PTSD, post-traumatic stress disorder, right? The person below, pretty dramatically severe depression, anxiety. We saw resolution of symptoms in nearly everybody, and improvement at some level in basically everybody at the post scale. And most people end up holding it out even to 6 months with a single dose. This is traumatic brain injury disability. So it's called the HUDOS disability scale. And the idea there is that these are folks who are kind of moderate, mild to moderate severity on disability from traumatic brain injury. So they have problems with cognition and mobility, and some at the immediate post, but really this is a neurotrophic factor, so it takes some time to work and kind of promote healthier brain circuits. At the 1 month mark and the 6 month mark, you see a pretty dramatic reduction in their disability, and they're really in kind of normal ranges for disability from traumatic brain injury, which is remarkable because there's not been a therapeutic for that before. This is suicidal ideation, so how much they're thinking about wanting to end their life. And this is executive function, so how well these individuals are able to be kind of flexible in their cognition, be able to inhibit kind of feelings of wanting to do things that may not be useful to them, or their processing speed, right? How fast they can process information. All of that stuff was statistically significantly improved. And then we actually saw areas in the brain where the volume expanded. So we saw growth in areas that are involved in mood regulation. So the insula, the prefrontal cortex. And what's really cool, and I call this the Benjamin Button finding. But one of my postdocs is very interested in this idea that that you can train artificial intelligence, machine learning algorithms to figure out your brain age. Now, your brain age may not be your chronological age, right? You could be doing really well, let's say you're 50, but you're doing really well, you're exercising every day, you're listening to the speakers in the last couple of talks and eating well and all that good stuff. Your brain age may actually be 45, right? Alternatively, if you're smoking and drinking and not taking care of yourself and all that stuff, and your chronological age is 50, your brain may be 55. But if I scan your brain today and put it into the algorithm, and it says that you're doing great, you're 45. In a month, I scan you again, I put it in there, it's going to say you're 45, and in a month later, it's going to say you're 45, right? It's going to be very consistent on that, in that matter. And what we found was a reversal of what the AI determined to be the brain age of these individuals at an average of about nearly a year and a half, like de-aging the brain, which is pretty wild. So this is the group. Everybody's very committed, and this is our funding, and really appreciate all the work that's been done, and all the dedicated folks in the lab that are helping. So great, and folks that want to participate in studies, this is an email address for that. Okay.
Thank you very much, Dr. Williams. It's a fantastic talk, very interesting and compelling. We have a number of questions for you. As a reminder to the audience, please submit all questions via the QR code. I'll start with an important question that I'm sure many are wondering. Is SAINT available now for people with severe depression? Also, now that it has been approved by the FDA, are most insurance companies covering the procedure?
Yeah, so SAINT is approved by the FDA. Interestingly, one of the few circumstances where actually philanthropy funded all the studies that led to an FDA clearance, which is pretty remarkable and a testament to the Stanford environment. The clearance happened several months ago. There's treatment available commercially now, and there's a company that's doing that. And they've been successful talking to CMS, the Center for Medicaid Services, around Medicare paying for this for inpatient care, right? So people who are admitted into the psych hospital inpatient, that should be available in 2024. It's all looking kind of good in that way, and commercial insurance companies tend to kind of follow on that once the government has decided it'll fund those sorts of things. So. Overall, good trajectory.
Is there any indication in the data that you have so far about any age difference in the efficacy of the treatment? Because a question came in asking, is SAINT therapy available for teenagers?
Yeah, we haven't treated anybody under 18. We've treated folks who are 18 to 21. It's interesting, I had a postdoc who was looking at cortical thickness for SAINT effects, and said, well, we've got a positivity in the data, but it's really being driven by these 4 individuals. And I went and looked at the graph without knowing who it was, and I said, is it this person, this person, this person, or this person? And they said, yeah, how did you know that? And I said, well, those are the 18 to 22-year-olds, right? And they had more volume expansion in mood regulatory areas than the younger folks. So, signals that getting in early and treating people before this becomes a lifelong chronic problem is there. It still needs to be explored, and we still don't have clear answers on that. But, I think, I didn't talk about this earlier, but TMS, generally, in our approach specifically, there's, for the old form of TMS, there's like a 1 in 30,000 seizure risk that lasts less than a minute. We haven't seen that, with newer technologies, and that's the only theoretical risk. And people may have, big risk. People may have a headache after that Tylenol helps with and it goes away. But essentially, it's a pretty low risk approach. And so the idea that you could intervene earlier and get people out of these states before they become super chronic and the brain gets super wired down is an interesting one, and one that needs to be explored. So.
Yeah. Kind of going off script, but I have a personal question I think many people might be interested in. When it comes to this brain stimulation, you're using a magnet, is that correct?
Yes.
And what exactly about stimulating the brain with a magnet, like how does it drive activity to that area, or how is that working?
Yeah, no, it's a great question. And so, as we talked about earlier, we're trying to find this specific region that regulates mood, right? And once with the MRI we find that specific region, we're sending a signal in to tell that region to clamp down on the sadness region, right? So we send a signal from the first region that's kind of the governor of the sadness region down and kind of clamp down on the sadness region and kind of establish control over that sadness region. So that's the idea. That the rhythm that gets sent into the brain is essentially a memory rhythm, right? And that's what you want, because you want it not just to get better when you're under a coil, but stay better. And in order to do that, you have to send a memory signal into the brain, so the brain kind of remembers to clamp down and continues to do so. And so far, so good. That's we have some data that came out this week to suggest that you can actually flip signals that are going in the wrong direction and kind of send that right signal to reestablish that place in the brain as controlling sadness.
Yeah, the data you have on major depressive disorder are incredible. And
Thanks.
a great question that came through: can SAINT be therapeutically relevant for people with anxiety, OCD, bipolar disease, or addiction?
Yeah, so we have published data in OCD. We're about to publish data in bipolar disorder that looks good for bipolar depression. Anxiety is reduced in these individuals, and we've had some success in people with alcohol use disorder, reducing their quitting drinking. So I think, somewhere between signals to full-on studies, with other indications. So things are looking good in that front.
And in those other applications, are you targeting different brain regions?
Yeah, so with OCD, for instance, what we're trying to do is inhibit the brain region that's overactive in OCD. It's and just to kind of give people a sense, it's a different problem with different brain anatomy, right? And so instead of an area that's underactive, and you hear depressed people say, I just can't do this, and I just can't get myself to do it. In OCD, that's the opposite problem. People are doing like a lot of things, right? They may be washing their hands 100 times a day. They may be checking the stove 100 times a day. And so you actually want to send a signal to kind of normalize that in the other direction.
Yeah, so the idea then is that in these different conditions, there are different brain areas involved. And by using SAINT to more effectively target those brain areas and apply greater level of stimulation overall, theoretically, it could be more effective then.
Yeah, that's the idea. Yep.
Awesome. Okay. Is the stimulation of the brain another form of electroshock therapy? Is it done as an outpatient, or do you have to be in the hospital?
Yeah, that's a great question. So many people are aware of what we call electroshock therapy, or ECT. The goal of electroshock therapy, or ECT, which has been around since the 30s, the 1930s, is this idea of a therapeutic seizure, right? You want somebody to have a full-on seizure, and then the brain has a reaction to having that seizure, and then the thought is that in certain clinical populations, people get well, there's risk of kind of autobiographical memory issues in some people, that sort of thing. TMS, the goal is to not have a seizure. It's actually the opposite goal, right? You don't want to see somebody seize. You want people to be awake, people to be talking to you. They don't need anesthesia. Most patients find it to be helpful for them, but kind of boring. So they're watching Netflix. And I'll tell you as a physician, if the treatment is boring, that's good. All right. And so, people are watching Netflix. They're not having problems. So it's just a kind of a different, totally different kind of way of doing things and different mechanism potentially and different acuity level and all of that, but it is similar in the sense you are interacting with the brain. That's the similarity.
So for those who may want to participate in this medical research, are you accepting subjects in any of your trials, and do you have to live in the Palo Alto area?
We definitely are, and thanks for asking that question. And we're accepting folks nationally. I mean, I think we even had one international patient. So you don't have to live in Palo Alto for a lot of the studies. People will fly in, and we have tons of ongoing studies, and so we're looking for patients. So if you yourself or you have a relative, I think there was an email address up on the screen earlier. You can just you can email us and we'll get you in.
Awesome. You spoke a little bit about psychedelics. Question came in, can you discuss the pros and cons of microdosing, and I'll add, or macrodosing psychedelics, and if you think they will become more mainstream for care?
Yeah, so the psychedelic story is interesting, right? So it's kind of depending how you think about it, the second or third time people are thinking about these substances, right? And so the first time, you could think of as kind of, in indigenous cultures and in places where it's part of the tradition. The second go round is, Western psychiatry embraced psychedelics, and then there was some, potential issues with that, and I could kind of get into that, but essentially, these substances have a way of affecting folks to kind of have certain perspectives. And then, the third go-round is really happening now, right? And so this idea of psychedelics, and it's really happened quickly. I think the public view of it's changed quite a bit over the last 2 years. So much so that, the study that we started in 2018 that I showed you was a little bit unusual back then, and now kind of mainstream, it seems. These are still Schedule I substances that are illegal in the United States. They are pretty far along the FDA pathway. Some of them are imminently going to be approved in the next year, it looks like, in the case of MDMA. But a lot of work to be done, right? And they're all administered in kind of medical settings. And so the question around microdosing or macrodosing on your own, alone, you wouldn't take a cardiac medicine by yourself. You wouldn't take a diabetes medicine by yourself. So the idea of taking something like this by yourself, it's kind of a risky move and is not really aligned with the ways that the medical community as a generality is looking at this. You got to be safe.
Yeah, certainly there are a lot of precautions taken, and a relevant question, I've read that psilocybin can increase the risk for schizophrenia. Is that true?
Yeah, it's also a great question. So there are concerns out there, and that gets back to this, the 1960s thing. There are concerns out there that these medications do have, risk for increasing your likelihood of having, a given psychiatric condition. If you look at the population and you look at folks who go into emergency rooms and, say they took psychedelics at some point in their life or didn't, there are lower rates for kind of all mental illness in the individuals that have had a lifetime exposure. So at the macro level, that doesn't appear to be on average a macro risk. At the micro level, we just don't have enough data to say that, right? At an individual person level, if you do this, is this better or worse for you? And that's why you need FDA-approved studies to help us sort that out. And people who have serious mental illness and they're trying everything else and nothing's working, and then they're looking at these sorts of things. But it is tricky. I mean, there's the risk-benefit profile on psychedelics is say probably a little bit more than stimulation that I described earlier. So.
Yeah, and from what I understand, for these trials that are being done on psilocybin, there's some pre-screening in terms of family history and risk level, right?
That's right.
So a follow-up question: what are your thoughts on ketamine treatments?
Yeah, so we did a study published in 2018 in the American Journal of Psychiatry where we showed that if you co-administer an opiate blocker, so a drug that blocks the opiate system, you block the antidepressant effect of ketamine. So it's not, opiates don't seem to be, sufficient, but the opiate system seems to be necessary for the antidepressant effect. And so if that's the case, right, that it's acting on the opiate system, it is tricky for all the reasons that we all know, right, of other opiate medications that have problems. And so it's, again, you need to really talk to your doctor about that.
Yeah. So back to Saint, do you imagine a future where Saint will be available as a frontline treatment for those who are newly diagnosed with mild to moderate depression?
Certainly in an emergency setting, right? Like, I think that, if somebody's, maybe they've been depressed a month or two, it's just very severe, and they end up going in an emergency setting, and they may not have even tried anything yet. I think it certainly will be in line for that, just because of the temporal aspects, the time aspects of that. Somebody that's that severe. If somebody needs to go in the hospital for depression, they need to come out of the hospital well. I mean, that's my view of it. That's how the rest of medicine works. You go into the hospital for something, the goal, I think you talk to every doctor at Stanford, the goal, is that you leave better than you came, and that's what we're trying to do for this. And I think in that setting, that makes a lot of sense.
Yeah. I mean, the data, again, you presented with 90% remission rate is incredible, though the rapid acting sort of effect of it also seems really impressive. Is there anything, does that compare to any existing treatment that is that rapid acting?
Yeah, off-label IV ketamine is fast. It's actually faster. The problem with IV ketamine is that, it on average lasts 7 days. So it's clinically kind of problematic, because I stopped calling it a depression treatment and started calling it a depression vacation, right? You do a single infusion of ketamine, you're going to get about a week, and then you're going to go back to your depression. With this, instead of a half a day, maybe it takes you a couple of days to get better. But we followed people out for 6 months for the inpatient trial we did. Most of them were still not suicidal at 6 months, right? So it's you really, for that, you really need to do something that is going to get somebody to a real next step, right? Which is more in the months to years time frame, not the days time frame. Yeah.
Has any of your Saint work been with ADHD patients, and any work with tinnitus? Can you treat multiple issues at once?
Yeah, it's a great question. So we've had people who had comorbid ADHD and depression, and their concentration certainly got better. It's hard to know in those cases, because there's some overlap between concentration problems from ADHD and depression, but but those folks said their concentration was quite a bit better. Tinnitus, we were partnering with some folks in ENT around that question, and can you kind of knock out the tinnitus sound by affecting auditory cortex, the part of the brain that processes information coming in from the ears. And, so far so good. The preliminary data that's come out of other people's labs looks really good, and we think we've got a way of doing that. The bigger question that kind of comes out of that really is this question of, could a neurostimulation approach treat multiple things for me if I have multiple targets and I have multiple kind of, stimulation strategies? And I think the answer is yes to that, right? So, if you have depression and ADHD and tinnitus, could you get 2 or 3 targets, and you can kind of get better from that combination of targets, just like we take multiple medicines for multiple comorbid conditions, right? And actually just being purely depressed alone, it's hard to find. Most people are dealing, especially older adults, are dealing with multiple things, as some of you know. And so, I think that's totally a future, and we're going to come up with new technologies that let us do that let us stimulate in multiple places and treat multiple things at the same time. And it's early days, right? I think in psychiatry we're in the 1940s cardiology understanding and technologies, right? But you can see how cardiology is today, right? They have a hammer for every nail, right? They pretty much have a solution for every problem, and they're really just in miniaturization mode, much more than find the solution. It's just like, how can we make these things smaller, non-invasive, but they basically have a solution for every problem, right? And I always tell people I'm a little bit jealous of cardiologists in that way, you know, but we're trying to go in that same direction, right? Where we're trying to build a bunch of tools, you know, my group, other groups, trying to build a bunch of tools, put them out into the world and figure it out with the goal of figuring out better ways to do it. You know, I hope that we don't have this like massive stereo system sized stimulator device in 20 years, that we can miniaturize that we can find ways to do it better.
Yeah, because truly at the forefront of that.
Yeah, thank you for that.
Is depression genetic or environmental? If depression runs in my family, are there preventative measures I can take to stave off the onset of more severe disease?
It's both, right? And that's true for a lot of medical conditions, right? There's one part genetic, you know, and there's one part, you know, environmental risk. And that's good. You know, it's not an absolute certainty that you're going to get a given, you know, problem just because of your genetics, but at the same time, you know, if you do have, you know, familial risk, then, you know, your environment and the way you interact with your environment is particularly important, right? And so, you know, and I think that's true for heart disease. I think that's true for cancer, and that's true for depression and psychiatric illness as well. So.
You spoke a bit about hypnotizability. I'm sure many people are wondering how hypnotizable they are. I mean, are there any traits associated with hypnotizability or anything like that? Yeah, so there is one thing that people can kind of tell. So it's called the absorption scale, Tellegen absorption scale. So if your significant other or parent or child tells you, hey, you know, you really get into that movie, and like I try to tap you or wave my hand in front of your face and you're like locked into that movie, you know, you have a decent chance you're probably pretty hypnotizable. So that's called absorption. But I have no idea how hypnotizable my friend here is, and I'd have to do a bunch of maneuvers to figure that out. But it's interesting, right, that a subpopulation of people, about 10 to 15% of people, they will, under certain circumstances, surrender volition, surrender control of what their brain and body are doing, you know. And so understanding that's important, right, because it tells us more about our humanity. Yeah. So. And so what you're hoping to do is potentially open people to become more hypnotizable. Is that right, through the work you're? Yeah. So the idea is, you know, if you want to quit smoking but you're not very hypnotizable, and you could have brain stimulation change that trait for you, you know, and that were to help out with you quitting smoking, that's a good thing, you know. But it's an open question. We have a lot of work to do on that front. The depression thing I showed at the beginning, you know, the stimulation approach is the furthest along. We know the most about it. Yeah, interesting. Do any of the therapies you're working on help people with addiction? Definitely. So we're seeing with the stimulation approach that I talked about at the beginning, that SANE approach, that folks with comorbid addiction are reducing, you know, we have the most data on people with alcohol use disorder, and they're reducing their drinking. It's great. The Ibogaine story that I told third, that's a substance that is particularly potent addiction interrupter, and we actually have data that I think 12 or so of the 30 people had alcohol use disorder, and all of them cut their drinking down, and most of them quit drinking altogether after. And you know, we even had people coming in and saying, I don't know why, but I just don't drink coffee anymore. I don't really want to drink, you know, which I'm like, wait, what? I drink a lot of coffee. You know, basically everybody, you know, reduced or eliminated coffee, and they weren't even intending to do that, which was kind of a wild observation. We think about, when you do open label trials, you know, there's a certain amount of placebo that goes into all that. So all that data that I showed you that was open label trial data is, you know, there's some aspect of placebo, but it's based on something called expectancy. So if I'm doing a depression treatment and I think it's going to help me, I'm going to have more of a chance of having a placebo effect. But if I'm doing a PTSD TBI treatment and I think it's going to help me in those domains, and I don't have any idea that my coffee use is going to be affected, and I stop drinking coffee, the chances that's placebo are lower, right? Because I don't have any expectation that's going to happen. So it's more random in that way. And that's what's been cool about that study, is we're seeing a lot of what we call off-target
sorts of effects where like our target was to look at X and we're seeing other things change. So.
It's awesome to see this question come through. Someone asked, are you looking for graduate students or research associates?
Absolutely, yeah. So we're always looking for new folks to work in the lab. My email is nolanw@stanford.edu if grad students or postdocs want to chat.
All right, so final question. A number of people have requested information on participating in a study. Can you again repeat the web or email address for study participation?
Yeah, can anybody in the back, could we put that
slide.
That slide up with the email? If you email us, we'll get back in touch with you. One of the team will get back in touch.
Well, I'd like to thank you again, Dr. Williams, for a fantastic talk. My pleasure.